So it wasn't done on purpose that this lecture is last here. It's the most speculative lecture of all. So what do we do beyond checkpoint inhibitors? First of all, there is a reason for us to explore beyond checkpoint inhibitors, because you already have seen the results in first-line and second-line therapy, and the reality is that many of our patients never respond to these therapies or have an initial stabilization and then progress. So there are many complexities to the immune system, and how to address escape and resistance is a science, but we're trying to translate that science into the clinics, and things are moving quite fast. So I summarize the reasons here why we need to explore novel immunotherapies and combinations. I'm not going to read the slide. We think that there is more room for improvement. So this is, not to confuse everybody, but this is the requisite slide that you have to have in every presentation to show how complex the co-stimulatory and co-inhibitory receptors and ligands are that are crucial for interaction between T cells and tumors with tumor antigens. And the reason I'm presenting this is because almost every one of these molecules that you see on the slide here is now the subject of either preclinical or clinical investigation, because most probably they're critical, but at different junctures. A simpler way of looking at the question of what to do beyond checkpoint inhibitors is to think about immunosuppression in the tumor microenvironment and what are the factors that we could potentially target. So soluble factors can suppress the local immune response. An environment that is hostile for infiltrating effector cells may be suppressing our response. Then immunosuppressive soluble factors may be secreted by the tumor cells themselves, myeloid-derived suppressor cells, other infiltrating cell populations that are immunosuppressive, and then finally, the tumor may be losing antigens, or there may not be the machinery present to recognize or present these antigens. So, again, this is adapted from the original Chen and Melman paper, the immune cell cycle and potential points of intervention. And you can see that some of the classes are already being explored. So I'm going to try to use my marker here. Anti-CTLA-4 I've discussed about a lot. Some of the cytokines are starting to emerge as novel targets with real results. And then some of the co-stimulatory molecules are also being explored. There is some clinical results that we are obtaining already with anti-VEGF agents. I'm going to speak about CAR T cells and T cell therapies in general, very much in the future, but the future is now, and then IDO inhibitors. So, look at this slide. I think I needed to have this slide in here because these are all areas of focus. And to simplify this slide, I have to say that most probably there are about 400 combinations of different agents and about 1,200 trials that somebody counted at Citi that are occurring with all these combinations of different agents, different therapies, and different approaches. So I'm not going to go over all of this, but because there was a question about what are co-stimulatory and co-inhibitory molecules here, I just need to read the first two lines of this slide. So co-inhibitory receptors, along with PD1, are LAG3, TIM3, KIR, TIGIT, and VISTA. There are others too. Co-stimulatory that are in clinic being explored, 4-1BB, urelumab, for example, is an agent, OX40, GITR, CD27, and ICOS. Many of these are going to be in an academic center near you or being explored right now. So a little bit more about IDO, because the trials are fairly advanced and phase 3 studies have actually been announced in combination with different molecules. So what is IDO? IDO inhibits T-cell activation via tryptophan catabolism. Local depletion of tryptophan results in production of this immunosuppressive molecule called kynurenine. High IDO expression is associated with a decrease in the immune cell infiltrate and an increase in regulatory T cells. Preclinical models, of course, they were done in a KRAS mutant lung cancer model and in breast cancer, but it's not specific to KRAS, have shown that pulmonary metastasis can be decreased, the tumor burden can be decreased with IDO gene disruption. So there is some preclinical validation of this target. This is the ECHO 202 Keynote 037 clinical trial, which is a basket that I presented a minute ago when I was talking about first-line therapies. And the cohort of patients that was treated in here was divided in 2 groups for non-small cell lung cancer, high expression more than 50% or less than 50%. And I think I showed the results very briefly in the waterfall plot a minute ago, but this is a very typical population of patients, but all are immunotherapy naive, just to keep in mind. Those are not patients that are refractory to immunotherapy. And the results are very exciting, I think, for first-line exposure to immune therapy. These are remarkable responses, and therefore there is generalized enthusiasm about targeting IDO in combination with checkpoint inhibitors. Some of the responses are long-lasting, and this slide is trying to demonstrate that the responses occur irrespective of PD-L1 status, but you can see that those numbers are really tiny, so we cannot really make that statement. Adverse events are important here because this is a combination that is better tolerated than anti-CTLA-4, anti-PD1 combination. It looks like we are going to be able to treat these patients with more ease, although we have been able to overcome the toxicities of anti-CTLA-4 with expert management. So in my mind, epacadostat is a highly promising molecule. There are other molecules in the class. I think based on what we have seen so far, it is more likely to enhance responses in PD-L1 positive enriched territory rather than induce responses in PD-L1 negatives. And we'll see how this goes. Now, the antiangiogenics, I already described the rationale in my prior slide. There are several clinical trials ongoing in other tumors. Remarkably, renal cell carcinoma has results. These are the results in non-small cell lung cancer that I think I went over a minute ago. Again, these look remarkably high for this population of patients. Again, very well selected, but 1 complete response and 7 partial responses. So this is a promising approach that is being explored further. What other promising targets do we have? I try to choose the positive targets based on what is already in the literature or what has been presented in meetings. So this is a little bit my choice of what I think is exciting. So targeting escape mechanisms such as JAK-STAT pathway or loss of existing immunity, tumors that are becoming cold, targeting the innate immunity space with Toll-like receptor inhibitors, RIG1-like receptors, STING. Those are mostly intratumoral injection therapies as they are developing right now, so it's an interesting approach, but highly interventional at the moment. T-cell engagers and T-cell bispecifics are emerging, so targeting two at the same time with one agent. We've seen some very early results of this approach. Cytokines showed great results this past week at Citi. Both IL-10 and IL-2 presented their results, and I'm going to have them in subsequent slides. CD38 is emerging as a resistance mechanism upfront to PD1 inhibitors, maybe through epithelial mesenchymal transition mechanism, and that is also being explored in clinical trials in frontline therapy with daratumumab. Combinations of anti-PD1 with antiangiogenics, anti-CD73 in targeting the adenosine pathway, which is an immunosuppressive pathway, also has early signal. And finally, combinations of PARP inhibitors and anti-PD1s in damaged DNA response pathway tumors. That is also emerging as a very interesting approach, not just in lung cancer, as you know, but ovarian cancer, triple-negative breast cancer, and a number of other tumors. So I wanted to share with you the results that were recently presented at Citi last week because they appeared to be encouraging in this area. So we saw a representation of a study with this molecule human IL-10 in combination with immune checkpoint blockade. The background on IL-10 is that it has anti-inflammatory functions and stimulates the cytotoxicity and proliferation of antigen-activated CD8 T cells. And the partial responses were seen in settings beyond lung cancer. There were 4 out of 16 patients with renal cell cancer that were treated with this molecule as single-agent therapy that had responses. And then in the non-small cell lung cancer territory, it was previously presented that 2 out of 5 patients were having responses when treated with combination of IL-10 and pembrolizumab. So we saw a more expanded cohort at the meeting. The bottom line is that the response rate is consistent. 38.5% of the patients had responses, and this included both PD-L1 positives and PD-L1 negative tumors, which is very interesting. There was also pharmacodynamic work included in this presentation, which suggests that the mechanism that is postulated exists in the tumor microenvironment. Another interesting approach is combining HDAC inhibitors with checkpoint inhibitors. And again, there was a clinical trial with very early results that demonstrated an interesting signal in patients with both immunotherapy naive disease as well as immunotherapy exposed with progression. This clinical trial showed a response rate, respectable response rate of 24%, but more remarkable even, I think, in the setting of refractory disease, a 10% response rate. This is really the area where most of us will be scratching our head in a couple of years because we really don't have any proven therapies beyond checkpoint inhibitors or any combinations so far that have shown activity in the setting of either intrinsic or acquired resistance. The adenosine pathway is an immune suppressive pathway, and there are several ways of targeting it. Anti-CD73 is one of them. Another way is adenosine receptor antagonists. And this molecule was presented last week again. 26 patients were treated, and there were 2 partial responses with combination therapy, and significantly increased CD8 T cell infiltration, mean 2-fold in the tumor, as well as interferon gamma pathway gene expression biopsies. Nectar-214 is a pegylated IL-2 that is biased with signaling preferentially activating and expanding effector T cells and natural killer cells. And the strategy was a basket strategy in tumors where monotherapy with checkpoint inhibitors had already shown activity. So the preliminary results showed a very encouraging signal in melanoma. We had the first encouraging signal in non-small cell lung cancer at the meeting, and based on that signal, this study is now enrolling multiple cohorts of patients, including patients with high expression in frontline, PD1 negative in frontline, as well as patients with refractory disease. This is the overall waterfall plot that was shown at the meeting. You can see that it's highly represented. Melanoma is highly represented in this waterfall plot, but in between are patients with non-small cell lung cancer, and remarkably, we had one complete response in immunotherapy naive patient with 0 PD-L1 expression, and there is a second one that I have in my practice that's unconfirmed yet. So there is something to this combination as well. These are the data. Vaccines. I think there is high promise in the area. After decades of disappointing results, we now have a very powerful tool in our pocket, which is checkpoint inhibition in combination with vaccine therapy. And we also have a second powerful tool, which is the capability of doing next-generation sequencing and uncovering epitopes in tumors that we can then include in vaccination. So this is, I think, one of the promising strategies that we're going to see emerge in the future. It's very early, so I don't have any results. I just put the names of 2 companies there that are advancing in clinical trials in non-small cell lung cancer, and most probably, again, next year, Corey or somebody from this group will be presenting some preliminary results. Okay, how about T-cell therapies? I think that's one of the most common questions we all get. What is going to happen in solid tumors with T-cell therapies? And I wanted to make the distinction that there are 2 ways of doing T-cell therapy in tumors, actually more than 2 ways. But the simplified schema here on this slide is engineered T cells and CAR T cells. So the genetically engineered T cells target specific tumor-associated antigens through a TCR that is modified to target a specific antigen. This is transduced into T cells of healthy donors, and the major limitation of this therapy is that it is restricted by the HLA of the major histocompatibility complex. Frequently, tumors escape these targeted therapies by downregulating the specific MHC class expression. So CAR T cells are the next step in therapy. You know, there is huge enthusiasm. There have been 2 approvals for patients with hematologic malignancies. And we really think of it as maybe the holy grail for solid tumors as well. CAR T cells don't have the disadvantage of being limited by MHC. There is a difference. They are synthetic receptors that enhance T cell anti-tumor effector function. And this occurs totally independently of MHC class. They can target cell surface targets, lipids, carbohydrates, and proteins. Now, there are many challenges for CAR T cell therapy and T-cell therapy in the solid tumor setting, and those are summarized here. One and most important is access of these cells to the tumor. And this can be overcome with either local injections. Some people in this room most probably are participating in strategies with intrapleural administration, of CAR T cells for mesothelin-positive tumors. There is also immunosuppression that occurs in the tumors that can be overcome with checkpoint inhibitors, but checkpoint inhibitors require constant administration as part of these T-cell therapies, not very, very practical. And therefore, second-generation CARs combine activation with co-stimulatory signals, and to prevent T-cell exhaustion, they insert a PD1 dominant negative receptor in the CAR T-cells. So the major limitation role, though, for solid tumors is our lack of knowledge of the specific antigens that we should be targeting. We have targeted antigens that are common to many tumors and not very likely to work in solid tumor settings, such as lung cancer, with a myriad of mutations that we already know these tumors harbor. So the idea is that the next generation of CAR T will target tumor-associated antigens that arise from gene mutations and lead to novel peptide sequences. And I think then we may be able to have similar successes as the ones that we saw in liquid tumors. So in conclusion, and I know there is exhaustion in this room already, there are several promising strategies with preclinical rationale and early clinical signal. None of these are going to be successes without large clinical trials. And that's the problem, that the patients are not unlimited. And we have so many strategies that we are exploring in limited populations that we need to think of smart ways of combining these therapies, maybe in basket or umbrella clinical trials. And we need to start thinking about personalizing these approaches, because we cannot assume that all these strategies are going to be positive in all comers. So we need to refine our strategy for biomarker development. Another smart way of exploring these combinations is in neoadjuvant settings, and we need to encourage this type of clinical trial and maybe encourage thinking surrounding potential approvals of agents in this neoadjuvant setting. We need to use alternative sources for biomarker development. We need to think beyond tissue because it's hard to do repeated biopsies in our patients. So circulating free DNA is one of these approaches. And finally, of course, we need to move beyond the single biomarker, but that was eloquently presented by prior speakers. And with this, I'm going to stop and hope for the future.